8, 7, 6, 5. And welcome everybody to the meeting of the South Tyneside CCG governing body. Once again, we're holding this meeting virtually using Microsoft Teams rather than in one of our usual venues in South Tyneside, as we're still continuing to be people who are on the call also to introduce themselves, so anybody who's watching on YouTube, as we are being streamed live on the CCG's website for transparency purposes, will know who we are. So I'm going to hand over first of all to Dr. Neil O'Brien. Neil.
Yep, hello. Hopefully you can all see me because my computer just went a little awry there. So again, I've just provided a summary report. As I know usually
Neil, whoa. Just doing welcome and introductions, Neil, first for now. So just introduction to who you are and hand on to somebody else.
I'm sorry, it's just my computer completely froze just then. So so yes, I'm Neil O'Brien. I'm Chief Clinical Officer for the CCG.
Kate.
Hi, I'm Kate Hudson. I'm the Chief Finance Officer and Chief Officer for the CCG. I'll pass to Tom.
Morning everyone, my name is Tom Hall. I'm the Director of Public Health for South Tyneside. Pass on to Matt.
Morning, my name is Matt Brown. I'm Director of Operations here at South Tyneside CCG, and I'll pass over to Jeanette.
Morning, my name's Jeanette Scott and I'm the Executive Director of Nursing, Quality and Patient Safety at the CCG. Pass on to Pat.
Pat, you're on mute there still. You still are. Well, maybe Pat's having some problems with the microphone. Oh, you're there, Pat. Nope, gone again. So Pat Hall's the one of the lay members with the portfolio covering patient experience, quality, and primary care. I think Louise Lydon would be next.
Good morning, I'm Louise Lydon. I'm a community pharmacist and the primary care professional on the governing body. Pass over to Tarquin.
Well, we do seem to find quite a lot of technical problems this morning. Some people's sound is coming and going, some people's vision is coming and going. I'm aware there's been some engineering works to some of the broadband. I'm aware that one of our colleagues is also having difficulty joining the meeting, so John Whitehouse would be joining the meeting. There's some initials JW. John, are you able to?
I have joined, but it's on my phone, Matthew. Couldn't connect through my laptop, so I apologise for the poor picture quality, but I am here. I'm John Whitehouse. I'm a lay member for Audit and Risk.
And Tarquin Cross, his sound was coming and going as he was introducing himself. He's a secondary care member of the committee, and he's only on a microphone rather than a camera today. We've also got with us Keith Haynes, who's governance advisor, and Andy Sutton, who's taking the minute. And I think that's everybody introduced. So apologies if the technology does break down and let us down further through today. It's not something that we've got much control over. We've also got apologies from Paul Cuskin, who's unable to attend today, and from Sue Ross, who's very newly appointed Corporate Director at South Tyneside Council, who's really just in an induction phase of her role at the moment and unable to attend today as well. So if I can just note declarations of interest, there's a whole bunch of us who have interest in other organisations within the NHS. These are well documented in previous minutes and will be documented again, so we don't need to declare those again. I've had a look through the agenda and can't see any reason why anybody with those interests should be excluded from any of the conversations today. If anybody has anything further to add on declarations of interest on items on today's agenda, then now's the time to let us know. Nope. Well, in that case, we can move straight on to the draft minutes of the last meeting. We'll go through these for accuracy and matters arising at the same time. Colleagues, if page by page, please wave your hand if you spot anything that needs to be amended for accuracy or want to bring anything up as a matter arising. So page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11, page 12, 13, and finally page 14. Well, quite amazed that we've got through that many pages without any corrections or matters arising. That must be a first. Let's just move on. Next item on the agenda is question time for members of the public. Now, obviously, members of the public are unable to interact with us via Teams. What I have done is I've arranged for a member of staff, hopefully, to be monitoring the CCG inquiries inbox email. So if anybody does wish to ask any questions during the course of the meeting, they can do so by emailing the CCG inbox. The address for that is styncccg.enquiries@nhs.net, I believe, and its details are on our website via the Contact Us section. So hopefully, if things work, anything emailed to that inbox before the end of the meeting will appear collated as a little file for me, and I'll be able to ask members of the governing body questions on behalf of members of the public, if that all works. So this is just, we're trying out this time, hopefully it will work. Right, let's move on to Neil and your report. You're raring to go before, but now's your chance.
Okay, thank you. Yes, so you've got the report there. Hopefully you've had a chance to read it. I'm still developing how I do these reports, and I do hope you find them useful. But again, give me some. Appreciate any feedback either in the meeting today or via email. It's pretty much a summary of the key meetings or bits of information that I've gleaned over since the last governing body. So just to very quickly go through it, the Nightingale Hospital, there have been government announcements of more funding to keep the Nightingale hospitals going, and I think they are a valuable insurance policy for the North East as we go through winter. The current plan is that they will continue with those until this coming winter has passed. But obviously that's under very regular review. The costs of keeping it there are actually not that high, but as I say, it's a valuable resource in case our hospitals become overrun with either a second spike of COVID or a bad flu year. On testing, I think testing now is pretty much embedded. A lot of the early, very public issues regarding the testing nationally have been ironed out. Antigen testing, which is the nasal swab. That what we're looking at, well, there have been some recommendations about how we extend that into care homes. So regular testing is going on for asymptomatic individuals in care homes. Antibody testing has been offered to all healthcare workers. But again, the value of antibody testing is limited because just because you've got antibodies doesn't necessarily mean you're immune, and you can't really take any, there's no modification in either lockdown arrangements or PPE requirements just if you have an antibody test. But it's given us some insight anyway into the levels of exposure to coronavirus in the public. I don't know if anyone saw in the newspapers, but it was reported from Durham that there was, I think it was 1 in 9 individuals who worked in general practice actually had a positive antibody test. But again, that was reported in the newspapers. I haven't seen the detail on that. Just to pick out some other interesting snippets, I'm leading the Strategic Flu Board this year. We've got a very, very different approach to flu this year. We have to have a very successful flu programme this year to protect the public. Whilst all of this COVID stuff is going on, it makes actually giving the flu vaccine much more difficult because of social distancing and PPE requirements. I'm establishing a regional project management office to coordinate the PPE, vaccine supply, communications to support a primary care network-based delivery of the flu vaccine. For many years now, primary care has delivered a very successful flu programme. We don't need to reinvent the wheel. We just need some valuable support, I think, for primary care. But also alongside that, we have got half an eye on when a COVID vaccine comes. How will the region respond to that? How do we identify at-risk populations for that and get the vaccine out safely? So all of the planning we are doing at a regional level is to support local areas for the flu vaccine, but also thinking about when a COVID vaccine comes so that we are at least ready for that. We've been through a number of planning sessions with the ICS, and we had some feedback that our planning, certainly approach to planning and bids for capital money felt very joined up in the ICP. We put ICP level bids together as commissioners and providers together, and it really did land very well at the ICS, and I think will stand us in good stead. There have been, just on capital monies, local A&E departments within the ICS have been given an amount of capital money which has come down nationally to improve the flow through their A&Es and to improve emergencies. So that is available for them to get ready for winter. And the agenda on local integration. Sorry, can you still hear me? Because it's gone a bit funny. Yeah, the agenda on local integration is moving forward. I've had conversations with the chief executive of the local authority. I'm very keen to progress how we integrate our approach to commissioning and provision on a place-based level. And I think that's some interesting work. And we're actually planning a showcase event in September where Durham, Sunderland and South Tyneside can talk, learn and share about their approaches to local integration. There's some information in there from the ICS management meetings. There'll probably a couple of things I wanted to pick out. One is there is a real focus on diversity within the NHS, the Black Lives Matter movement. We need to think about locally how we respond to this. Yvonne Ormston's the Chief Executive in Gateshead and is an ICS lead on equality. So we're looking to see how we can formulate an ICS level statement or kind of principles of how we ensure that we've got equality right throughout our NHS organisations within the ICS. So there'll be more information to come on that. I wanted to mention Talk Before You Walk, or 111 First, as it's called nationally. It has been reported that Newcastle and our ICS is a pilot for the Talk Before You Walk. Basically, this is effective clinical triage for patients to ensure they get to the right place first time. It's how the system should work, but what we've learned through COVID is that if you put more clinical resource within triage through 111, that may be nurse practitioners or GPs, then a lot of patients are actually don't need to go to A&E. Now, we've all known this for many, many years, but we're looking at ways in which we can say from enhanced clinical triage from 111, directly book and say, actually, I can give you an appointment with your GP this afternoon, or yes, you do need to come to A&E, I'll book you a slot. We're trying to reduce the number of people who are sitting within A&E and improve the patient experience for A&E as well. So you're not having to sit there for, if you do have to wait for 6 to 8 hours, it's probably best that you do that in your own home if it's clinically safe rather than within A&E. There's a lot of work to do, though, to make sure we get this right for our South Tyneside population. So the North ICP in Newcastle are going first, and they're looking to go live in the next month or so. And then we will take the learning and plan and inform, keep governing body up to date on how we're looking to implement that within our area. And just to say, when we say implemented, it's not a massive change. I think it's reinforcement of what we already do. But yes, more detail on that to follow. Within the report, there's a lot of other local updates in there, which, as you can see, there's been quite a lot of really very good clinically led, patient-focused work, even despite the COVID work that's been going on, which is there for your information. And as the appendix, there's a few kind of national stuff, bits and pieces that are in there. So that's probably all I wanted to say, but happy to take any questions from anyone.
Thanks, Neil. Pat, you have a question, hopefully?
Right, can you hear me all right?
Yes, got you now.
That's good. Okay, thanks for your report, Neil. Actually, the feedback I can give you from your report is excellent. It gives us a lot of really good information, particularly from a lay member perspective. I'm really interested in this Talk Before You Walk, which does sound, a very interesting development. But I did note in your report there was a sentence around significant concerns regarding funding, as it hasn't been built into the plans. And I just wondered if there was any more detail you could give us on that.
So there has been some of the A&E capital funding put towards Talk Before You Walk, but that's not the big cost. The big cost would be revenue, ongoing funding of this, because the likelihood is we're going to have to put more clinical triage into this. Now, the exact costs on that, to tell you the honest truth, have not yet been worked through. The numbers that are in this report have changed again, and I don't think we fully understand the costs. And that's part of the national pilot, to understand what those costs are, and whether or not it is both good, is it good patient experience and value for money. So I think that does need to be worked through. There will be some cost to it, but we're looking to repurpose a lot of clinical time to work in a different way rather than buy additional staff, which quite frankly aren't there. So I think the costs, I know from the numbers that are in this paper, have significantly come down, but I can't tell you what they are yet. And that is one of our concerns about rolling this out. And I've made that known.
Excellent. Thank you for that. Matthew?
Okay, yeah. Did you want to ask a follow-on question, Pat, or
I did.
Jeanette? Yeah.
Yes,
Pat
please.
again, then Jeanette then.
Okay, thank you. Sorry, Jeanette. Thanks for that, Neil. That's really useful. And I'm delighted that you talked about patient feedback and I guess clinician feedback also. So I'm assuming from that pilot there's going to be an evaluation that will take all of that into consideration.
Yeah, we need so a few of the issues that clinicians have brought up that we need to ensure we get right are, is this and remember, we've been doing this clinical triage through 111 for years now, and GPs have been doing this for years, but we want to make sure that whatever enhanced clinical triage we put in place is the right thing for patients, is clinically safe, doesn't widen the gap of health inequalities, doesn't cause any issues with patients who have mental health issues, is good value for money, all of that kind of stuff is going to be built into the evaluation, because the pilot sites will be looked at for, potentially, is this a model that we roll out nationally? So I'm expecting we should get some funding for this because it's a pilot, but usually with that comes the requirement for a robust evaluation, which is the right thing to do. So yeah, more detail will come on that.
Thank you.
Thanks very much, Jeanette.
Thank you. Yes, I mean, I think we would all agree in principle this is the right direction of travel. We've known for a long time that patients should have access to very quick clinical triage, so people with the right skills doing the triage, getting them to the right place at the right time. We've known that for a long time. I suppose one comment from me is that this is very focused on ED departments, accident and emergency departments, or getting people to the GP practice instead of the accident and emergency department, but there's not a lot that I've seen, and it may be that it's just not evident in what I've read, around social care provision and support in the community, and whether or not additional services will be required in the community to make sure that people get that timely response that prevents them feeling the need to go to an emergency department.
So I think it's difficult, isn't it, when we talk about one particular thing. So we look at talk before you walk, and then you can think about all of the other issues that may well affect a patient in that patient journey. If I had the time and the inclination, I could give you a list of about 50 things, Jeanette, that we're doing within the community and within social care that actually improves access, quality, patient experience in those areas. They're not included in this in report or any reports on Talk Before You Walk because it would make the report enormous. But I think we all know, and we've all seen initiatives in the past that do enhance that offer to community services and social services. And I think the way in which health and social care have worked together through the COVID crisis, we need to work on how we embed that. And that really goes towards our integration agenda that we were talking about. So I think there's nothing specific within the Talk Before You Walk pilot about that. But what I would say back is that we actually have quite a lot of work and training previously on those issues. But social care needs more support, absolutely.
Thanks very much. I can't see anybody else waving their hands wanting to ask any more questions about that report, Neil. So we'll thank you for the report and I'll note it for the record. Thanks. Let's move on then to the next item on the agenda, which is the quality section. And first is the key assurance and risk report from the Quality and Patient Safety Committee, which I think again this time is going to be a verbal report from Jeanette. So over to you, Jeanette, for that. You're still on mute, Jeanette.
Apologies. So the report that is presented, and for some reason I can't find my notes, and I don't understand why. But the report that that is presented around complaints is a summary across the region. So I think we've asked for this previously. We thought it was important to be able to compare.
Jeanette, there was the, you're going to give a verbal report for the key risks report from the Quality and Patient Safety Committee.
Sorry,
complaints report.
Sorry, I've jumped to the wrong thing. I do beg your pardon. Apologies. So in terms of the summary of the quality and risks that discussed at the Quality and Patient Safety Committee, there's just some key things that I would like to identify. One is the published report from CQC for South Tyneside and Sunderland Foundation Trust from an inspection that they had over January and February. Overall, they were rated as good. And so, 2 services were rated as outstanding. So I think that's, so those services were the hospice, St Benedict's Hospice, and community services generally. So I think that's to be congratulated. There was 2 areas that required improvement, and that was the site, the Sunderland Royal Hospital site, but also community mental health services. There's action plans already in place addressing those actions, and that's something that's already been addressed. In terms of monitoring of mortality, so death, there's some changes being made around how NHS Digital records COVID-related deaths. So they're being excluded from something called Shimmy, just so that we're able to compare this period of time with last year and not look that it's been warped by that activity. But we obviously are monitoring very closely all COVID-related deaths as well. And the NIQOS, which is the North East Quality Observatory, is supporting trusts in the region to review all mortality data during the COVID pandemic. Specifically, the South Tyneside and Sunderland Foundation Trust, they held a Learning from Death Summit recently, and I know that there was CCG representation at that event where they presented a big piece of work they carried out reviewing all deaths over a period of time. And the key points that were identified was that no cases that were reviewed were deemed to be avoidable, and 99% of those cases definitely not preventable. So that's really good to know that there's been an in-depth review, and we've got significant assurance from the findings of that. They did identify a small number of some learning, but mainly about documentation and certification of death. So in terms of clinical care, there wasn't anything significant that was identified, and that's really good news as well. Care homes, just a very quick update: infection prevention and control training, with the exception of 2 homes which were part of the Barchester group who provided their own training to their care homes. We achieved 100% of all homes to be trained by the deadline, and we're continuing to train throughout July with an ambition of training 80% of all staff rather than just somebody in each 100% of homes being trained. And we've also demonstrated excellent compliance with the Enhanced Health and Care Homes National Return, with good links to the primary care networks and also the CCG leads. In terms of infection control, there was a letter from Margaret Kitchen, the chief nurse, regional chief nurse, went out to all provider trusts recently around the 2 metre distancing, social distancing distancing and the requirement for provider trusts to make provision to be able to maintain that, and that has caused some concerns around restarting activity, routine activity, and being able to maintain social distancing, which will mean that they have to reduce bed activity. And some services, such as the patient transport service with the ambulance trust, have identified that it's going to cause particular problems with the number of people that can transport at one time. So there's something that's been carefully monitored, and both South Tyneside and Sunderland CCGs have now been granted funding to look at enhancements to the infection prevention and control teams to be working across care homes and supporting primary care, and that's very good news. And the only other thing I was going to mention was the learning from the learning disability deaths process was put on pause during the height of the pandemic, but it's now been restarted, and there's a process in place to pick up that backlog. We've been able to successfully apply for some funding to support that, and so we're very focused on carrying out those reviews and identifying any learning and sharing that learning as quickly as possible. Happy to take questions.
Thanks very much, Jeanette. We'll invite questions from colleagues. Just whilst I'm talking, if anybody does notice a strange pounding noise on their computer at all, it's not the technology. Someone's just arrived with a pneumatic drill outside my house to dig up the road. So if that's transmitted, then I do apologise. So colleagues, questions for Jeanette, if anybody has any there. No, nobody waving any hands. In that case, thanks, Jeanette, for the report. We'll note that, and the assurances flowing through the Quality and Patient Safety Committee as well. Can we then move on to the complaints report? Now, this is down as Matt delivering this report on my agenda rather than Jeanette. So who's going to take this?
Thankfully, Jeanette, this is under Jeanette's remit, this one.
Yeah, I actually, thank you, Chair. I actually hadn't noticed on the agenda that it was down as Matt, because on the front cover of the paper it does have me, so I was expecting to present this paper. So this is a second time that I've tried to introduce it, jumping the gun again. It's really difficult when you're juggling with the screen. So this is a complaints report which has been presented already to the Quality and Patient Safety Committee, and it's a summary of complaints received by the by NEX, our Commission and Support Service, and it covers all complaints across the region. So by looking at the regional perspective, we see if there's any themes and trends across a higher number, because we tend to have very small numbers of complaints, so it's very difficult to pick up themes and trends with those small numbers. So I think the thing to identify is, the first thing is, there's only been 2 CCG-led complaints for South Tyneside, and neither of those were upheld. The main theme that was identified from the other complaints is around the patient transport service, and that's usually where people haven't met the criteria to access patient transport for appointments, and they complain because they feel that they should have been able to access it. The paper also includes a useful summary of service improvements that have been made as a result of complaints, and I think that's a really important point to note, because the whole point of investigating complaints and identifying themes, trends or root causes is that it's an opportunity to learn and improve. And so there's a number of process or service improvements being made across all CCGs, and there's a summary in the report. CHC does tend to feature quite significantly. It always has. It's a very emotive subject, and the complaints typically tend to be around either the funding, receipt of funding, or the process, or even the decisions and how they're communicated, and that that area, that particular topic remains the most frequent source of complaints. But there has been a number of improvements made around process to address the learning from that. And that was all I was going to pick out from the report, but happy to take any questions.
Thanks, Jeanette. And I would come to Pat and then Matt, I think. But my comment first, as Chair's prerogative, I guess, is that it's historically we tend to see complaints around IFR processes and CHC here, and I think it's a tribute to the work that has been done by the our changes in CHC and how we're changing how we administer that process over the last few years, that we're probably like the only CCG in the region now that's not had any complaints in the last year about its CHC processes. So that's really good feedback from me on those changes that were put in place jointly between us and the council over the last few years. So, well done to the CHC team in the joint commissioning unit. Pat, over to you first, and then Matt.
Thank you. 3 comments and a question, if I may, Chair. The comments are well done with regard to meeting performance indicators, because this does mean a lot to people who put complaints in, that their complaints are dealt with in a timely, appropriate manner. So it's good to see that. Also good to see an example of how a complaint regarding the patient transport did in fact lead to improvements to the actual system, not just addressing that one particular comment. And also good to learn of improvements introduced by the complaints team themselves, which I think is from a lay member's perspective, is a good indication and assurance of continual review and improvement itself. The query that I have is, whilst it's good to hear that we have very few complaints, I guess the challenge is, are we sure that we are capturing and asking for people to complain where they feel that service delivery isn't meeting their needs?
Thank you, Pat. Yes, I think it's a constant challenge. We have a whole programme of engagement, don't we, with the public, and they're always encouraged to give feedback. I would like to think that because we've improved the way we communicate with our local population, I think a lot of issues get dealt with very quickly and don't move to a formal complaint. So they're dealt with at the informal stage and don't become a formal complaint. So I don't think it's an indication that nothing ever happens, goes wrong, or could be improved. I think it's more of an indication that we're getting responding very quickly and getting things sorted really quickly before things move to a formal complaint. But we shouldn't be complacent, and certainly I know that whenever, and people frequently contact the CCG, the office, and they're always offered the advice around, would they like to make a formal complaint and would they like to be supported with that, or would they like to just speak to somebody and try to resolve it. So I know that that definitely does happen, but we don't know what we don't know, I suppose. We have to just be vigilant.
Thanks very much. Matt, do you want to ask questions as well?
Yeah, and just building on Jeanette's last point, I think we work really hard to be responsive. So particularly if you look at CHC, which was going to be my point, Matthew, you rather stole my thunder there. I think it is really encouraging to see that big change actually, and the big difference in since we made those changes. And I think that's testament to the work of Jeanette and testament to the work of Sarah Golightly and Joint Commission Unit and the local authority, working really hard on those issues. So that's really encouraging. And I think what we're seeing is we're working with people much more closely. So hopefully as issues start to arise, we're able to respond to them quickly rather than let them become challenges. And hopefully we're communicating in a way that people feel is clear. But we're certainly aiming to be as responsive as we can with any issues that are ever flagged with us.
Thanks very much both. And yes, congratulations to the whole of the operational team in their responsive manner in which they deal with concerns before they get to the stage of needing to be formal complaints, I guess, from the governing body to the whole team. Martin, if you could ensure that that's passed on, then that'll be great. Okay, colleagues, have comments or questions on this report before we move on? No. In that case, thanks, Jeanette, for that report. And we'll move on to the COVID update section, which we're doing together with the partnership section of the meeting. We've got a dual verbal presentation and the enclosure on the outbreak management plan from, I think, Matt Brown and Tom Hall. So over to you.
Yeah. So perhaps if I start and then and hand over to Tom to contribute. I think if you remember at the last governing body in May, we had a very detailed and comprehensive paper on all of the work that was underway on the COVID activity and response. And obviously we were really right in the midst of it at that time. And it's encouraging to see that since that period, we've seen a significant decline in the number of cases and I guess a reopening of society as things start to recover somewhat. I think it's really important to point out, you remember that when we're looking at the data in May, it looked as though South Tyneside had one of the highest positive test volumes in the country. But since we've seen the inclusion of all of the data across the country, that obviously has changed, and we're now much more in the middle of the pack as we'd expect to be. I think that the thing I just wanted to comment on particularly is, as society starts to reopen, we've got great challenges for the NHS ahead. And in fact, Neil and Jeanette have touched on this already. So as we're looking to reopen hospital services or general practice, clearly infection prevention control, the number of patients that can be seen at any time, the capacity of staff to be able to deal with patients, the number of beds we can have in the system, those are real constraints that we're going to have to deal with. And I'll come on to some of that in the recovery report. In the performance report. The recovery plan itself is being coordinated by the Alliance Business Group, which is a key partnership meeting for us, and has been led by all of the different alliances. And I guess we've set the challenge really for those alliances that we want to think about and be clear on how we're going to deliver an unequal response. So we know the burden of COVID has fallen unequally, and we need to be equally unequal in how we move forward with it. So, for example, primary care, general practice, we've had a great range of different methods of getting in contact with GP, for example, so face-to-face, phone, video consultation, but we need to make sure that we're actively targeting those groups who find it more challenging to get in contact with GPs. So we need to think about how that's unequal. We know that, for example, patients who have a DNA or do not attend for outpatient appointments, there's a much greater rate for our more deprived patients. So making sure that we target our access much more disproportionately towards those groups. And I think a bit like Neil touched on, the other part of the recovery planning is how we make sure this segues really nicely into the winter plans and the flu plans that we've got. So we've been really successful at delivering flu vaccines, for example, over the last few years, but we need to kind of stretch that to be able to deal with the infection prevention control challenges and go at a greater pace. And we're really fortunate in the relationships we have across the system that could stand us in good stead to do that. And just a final point, we recently established a local A&E delivery board across South Tyneside and Sunderland, which is looking at both winter plans and the flu plans in the context of COVID for both patches, working with that provider. Tom, I don't know if you want to add anything to that before we go to the outbreak management plan.
No, that's fine. I mean, I do have some of the latest figures if the governing body would like me to share those quickly. I'm happy to do that. I'll try and keep it brief, but it very much kind of reinforces what Matt's said already. If I just bring up my slide share, so bear with me. Hopefully this is the right one. Matt, can you give me a nod if you can see that? Yeah, show me. So just wanted to share the latest picture really with the governing body. We now in South Tyneside, according to the publicly available data that we have on COVID-19, we've had a cumulative total of 951 confirmed cases of COVID-19 in the borough. I've mentioned previously that one of the challenges with just looking at cumulative numbers is that it doesn't really give you a current picture of how things are. Obviously, most areas have suffered greatly with COVID-19, and Matt already explained how we've tried to rise and respond to some of those challenges. And I think hopefully this next slide gives you a sense of where we've been and where we've got to. So rather than looking at the cumulative number of cases, this slide shows you the rolling 7-day total of cases per 100,000 of the population. So it takes into account the size of your population. And it shows us the Northeast in red, England in orange, and South Tyneside in blue. You can see at various points, South Tyneside had significantly high rates of new cases of COVID-19 on a rolling day-by-day basis. But this is more or less followed the broad pattern across the Northeast and in England. But the thing I just wanted to highlight to governing body members is that, you know, since the early part of June and through into July, in South Tyneside, we've had extremely small numbers of new cases in the borough, which is a very positive thing. There is a challenge there. I've said before, the more you test, the more you tend to find. So we just wanted to make sure that we are testing appropriately in the borough. And although I don't have specific data to show you today, I can confirm verbally that we do seem to continue to be testing a lot across the borough. So we're busy trying to get more formal data on that, but our testing numbers are very positive. I just wanted to show governing body members this slide as well. This is quite an important slide for us because I think it to a certain extent addresses some of the challenges we had about our local COVID-19 data in the earlier stages of the outbreak. Governing body members will remember on the public-facing dashboard that Public Health England produces, South Tyneside sat as the third highest rate of COVID-19 cumulative cases in the country, behind Gateshead and Sunderland. One of the challenges that we did feedback at the last GB session on this was that that public-facing information only included one element of the government's testing strategy. In the early stages of this, we were very reliant on NHS labs and Public Health England labs. That's the so-called Pillar 1 testing route that was available in the early stages of this. We said at the time that we believe that because of good local relationships and a strong laboratory in Gateshead, that we had quite a lot of testing in the early stages of this. We expanded our testing strategy more rapidly than other areas. We were testing whole care homes, care staff, NHS staff. We were doing it remotely with the stand-up parade hub, and also ensuring that people could get tested at home if they couldn't, key workers could get tested at home if they couldn't get to the testing sites. We had a very expansive testing strategy, which meant that we found more COVID in the early stages of this. But then what we've always been missing is the other bit of the jigsaw in the public data, and that is the so-called Pillar 2. Now, Pillar 2 came online a bit later, and that's the national testing process that was put in place by the government, whereby people could request tests through the .gov.uk website or through NHS 111. That meant that people had testing kits posted to their home, or they were signposted to local testing centres where they could get tested. You may be aware that we had one at the IKEA car park in Gateshead for some time, that later moved to Great Park. And since then, we've had further local mobile testing units set up. We had one in Bolton for a period of time in South Tyneside. They're the so-called Pillar 2 tests. Now, for a long time, we didn't have that reported to us locally, and nor was it on the national dashboard. But obviously, it's another part of the jigsaw when you're looking at whole populations. Now, because we were very reliant on Pillar 1 testing in the early stages, you can see all this blue. These are the blue lines here, the blue bars here. And we were much less reliant on the Pillar 2 testing because we had such good local testing arrangements. So when it came to the point that the government added Pillar 2 data to Pillar 1 data, our rate in South Tyneside went up, as you would expect, because everyone's went up because they were adding new data to it. However, our rate only went up by 25% compared to a lot of other areas that had really quite large increases in their local rates. So South Tyneside dropped from having the third highest crude rate, cumulative crude rate of COVID-19 in the country, down to, I think it was about 23rd, 24th in the country. So we significantly dropped down the rankings, so to speak, when this additional data was brought on board. So I'm just telling you that to explain why we, in the early stages of this, we seem to have much higher rates of crude rates of COVID-19 in the population. That doesn't mean, of course, that we haven't we haven't struggled with this. I think everywhere has struggled with it, but I think it just goes to show that we maybe didn't struggle quite as much as the public data might have suggested. And this epidemiological curve just shows you that of recent weeks, these are like individual cases here. We're seeing very small numbers coming through our system at the moment, and I'll touch on that again when we come onto the outbreak management plan and the importance of that. And again, this just shows you that our rolling 7-day rate of cases in South Tyneside, just this orange bar here, we've actually got lowest in the northeast and indeed one of the lowest in the country. So our local rates have really dropped down. So we're really keen now to make sure that that continues. Obviously, we don't want to see a second spike. We don't want to see a resurgence. I just wanted to talk about the outcomes of COVID-19, and obviously it's been very sad that we've seen individuals who have died with a diagnosis of COVID-19. And again, there's been a lot of public debate about the data on this and what it really means. There's still a lot more processing of the data to come. The Office of National Statistics has really got its head around this now, and I think there'll be more and more data on in terms of local mortality rather than just relying on reports out of the hospital, which in many respects is quite unreliable and not comparable. I just wanted to show you the analysis that we're looking at most closely, and that's excess mortality analysis. This chart here shows the number of deaths we were having week by week in South Tyneside since the beginning of January. These weeks, obviously, week 1 is the first week in January, and then they follow through for the rest of the year. These grey bars show you how many deaths we've had in the borough in 2020 in these weeks, and these bold lines here show you the average weekly deaths from a 5-year period, 2014 to 2018. In South Tyneside, so it gives you the average of those years, which broadly tells you what sort of numbers we might expect to die at this time of year. So it's almost the expected deaths. It's very very crude term, I get that, but but this is how many people we would expect to have died in the borough during these weeks, and this is how many people have died. And then when the red bars start getting adding on top of the grey bars, that's where COVID-19 is mentioned on the death certificate as well. So you can see for the early part of the year, before we had the COVID-19 epidemic in the UK, our number of observed deaths, so this is how many we saw, were tended to be lower than the number that we would have expected on average. Then obviously during the COVID period, we had this increase in the observed number of deaths in the borough compared to what we would have usually expected to see. But since the beginning of June time, that level of observed deaths has really dropped down now, and we're seeing levels that are much lower than the number of deaths that we would expect this time of year. Now, this is not to kind of dismiss what's happened, and of course it's been a very challenging time, but it's an important factor to bear in mind that unfortunately particularly people who we know have suffered more with COVID-19, the demographics of people who have suffered more with COVID-19, i.e. those who tend to be over the age of 80, there is a level of expectation that people will die soon. How soon is obviously an individual thing, but it does mean that we may be seeing a situation where people who may have expected to have died at some point during 2020 actually died during the COVID-19 period, which is why it's really important that we look at how many deaths we observed versus how many deaths we expected. And this analysis obviously shows the year to date so far. It's also important that we look at this over a much longer period of time. So we may well see that evening out over time, where we see that the levels of observed deaths in 2020 may not be too dissimilar to what we would have expected otherwise. But that's just one way of looking at the data. I just quickly point you towards this line chart as well. This just shows you how South Tyneside has compared to the northeastern England in terms of the level of excess deaths in the population. So again, the UK, northeast and South Tyneside all had lower than expected levels of death for the early part of the year. We then had the COVID period. Broadly speaking, the northeast was about a week behind the UK, it's a week behind England, and South Tyneside about a week behind the northeast. And then South Tyneside had a lower increase in the number of excess deaths It also topped out slightly lower than the Northeast and lower than the England average, and then we saw it decline broadly in line with the rest of the country in Northeast, and now we've got this lower than expected number of deaths in our population. So this is something that we're going to look at over a much longer period of time, but I just thought it was of interest to the governing body members. So I will stop sharing there. Happy to take any questions on the data.
Okay, so questions on either the data from Tom or the progress and recovery planning update that Matt's given from any colleagues there. Pat?
Thank you, Chair. I mean, that's really interesting, and we've had a few governing body sessions looking at all of this, plus the recovery planning. And I think from a lay perspective, I think one of the big questions is making sure that we get timely data, localised data, and that's accurate data to allow us to inform our decisions about going forward on that local basis. But for me, as well as that, it's that sort of feedback from a number of areas that I'm always looking for when we discuss these things in the various sessions that we get, to get some assurance that we are taking on board that sort of experience in lockdown of people, and that we are addressing those levels of concerns at all levels. So I'm talking about, the sort of the clinical issues, the patient experience, the family, all of those social well-being issues as well. And so I guess my query is just looking for some assurance that we do in fact have that. I've seen evidence of it, but I think it would be appropriate in this meeting just to discuss that, please, if we may.
Yeah, if I perhaps answer that first, and I'm sure Tom wants to comment. So I think your point is extremely well made, Pat. So we're not just looking at, in the recovery or in the work we've done during COVID, not just looking at COVID and the disease and the impact of the disease on those patients who have it, but what does it mean to be isolated from society for 3 or 4 months? We're not just looking at the people who are vulnerable to COVID, we're looking at how we support the people who are vulnerable to isolation and the impacts of the forthcoming economic challenges and so on. So as a partnership, certainly through the Health and Wellbeing Board yesterday, through the Alliance Business Group, we're very much focused on not just the disease or the patient or the person, but the person in the context of their family and their broader life. And those things are really important. They all impact on health. So I can give you my firm assurance that those things are front and centre in our mind. And when we challenge the alliances to think about what they're doing in the recovery on learning disabilities, mental health, children, young people, it's not just about the healthcare aspect, it's much broader than that. So yes, absolutely, it's my commitment to do that. Yeah.
Okay, and then firstly, I don't know whether Tom wants to make any comments on Pat's point about data accuracy and timeliness, and then we'll move on to Jeanette and then Louise for further questions.
Yeah, so thanks, Pat, and totally agree. I think for a long period of time it wasn't acceptable, the quality and pace of data that we were receiving through. The formal routes of communication, I think that has improved dramatically. We now have access to individualized data, very timely data, which is good, and allows us to much more closely monitor the numbers in the borough and then how we might respond. I think of note that one of the things we've noted so far is that actually our local connections and relationships and that tacit knowledge is more pacey than waiting for formal results as well. So we worked hard to make sure, and I'll touch on it in the outbreak management plan, worked hard to ensure that we've got good connections with our key settings that we consider to be at-risk settings, to ensure that they're giving us the heads up if they think that something's going on. And that's the same across some of our key businesses and key risk sites in the borough, so that we know their HR departments, for example, in some of the key businesses, know that if they've had a number of people who've gone home with COVID-like symptoms, that they're just giving us the tip off, so we can be chasing the results rather than waiting for the results, and that allows us to have a much more rapid response. And so far, touching wood, that seems to be a another additional route for intel over and above the formal data reporting.
Thanks for that, Tom. So Jeanette, then Louise.
Yeah, just a very quick point. Thank you very much, Matt and Tom, for that. It's reassuring to see that once you've got the full picture, where you've got all of the data, that what looked very alarming initially has turned out to be, it was about how good we were at testing people and not having all of the data to hand. So it's an important point to note. Thank you for that update. And the only comment that I wanted to make was, I think this just demonstrates the importance of infection prevention and control, and going forward, how much of a priority that is. And I know that we're all committed to that, but I just wanted to note that.
Yep, I think that's a fair comment, Jeanette, and a really important topic which we will be ensuring we pay appropriate attention to going forward, I'm sure. Louise?
Yep, it was just a point maybe to consider. Would the governing body and public health teams like to try and communicate this out to the patients? Because obviously the North East and South Tyneside, the media have sensationalised the high rates, and I think that's caused quite a bit of anxiety to the public. And I think if they were in receipt of the correct information, and the fact that the South Tyneside patients have been really respectful and followed the rules, and it is perhaps just an indication of the success of the testing, if that could be communicated out just to relieve some of the alarm and concern that the patients have felt in the North East.
Matt?
Yeah, I think you're right, Louise. I think we should look to do that. So partly through this public meeting, through the Health Wellbeing Board, which was on YouTube yesterday, we're starting that, and I think we do need to think about how we get those messages out to try and, I guess, also show gratitude for the people of South Tyneside who've shown immense civic commitment. So, you know, those numbers can only come down if people respected the things that they needed to do to stay safe and to look after each other. So I think you're quite right. We should look to make sure we promote that and help people understand the real picture. So perhaps Tom and I will have a chat with the comms teams about how we best do that across the partners. Thanks, Louise.
Yeah, equally, I agree. It's not down to anything that we've necessarily done that our rates are low. It is that what the people of South Tyneside have been doing to get our rates down low. So we do need to recognise that, but we also need to recognise that we need to make sure that people are not over scared, but we also need to make sure that people don't have a feeling that this is all over and want to promote reckless behaviour. And it is a very fine line to tread, I guess, isn't it? But it's something that we can work on, I'm sure. Okay, I've not seen anybody else's hands waving at me, so we'll move on to the outbreak management plan, Tom, and I think you're just going to talk us through that.
Yeah, thank you, Matthew. And yeah, totally agree. Common sense is the way forward from here. I think I think the population and our local businesses and our key risk sites like schools and care homes have worked so hard to get on top of this, and we're in a good position now. And I just want us to remain on top of that. And I think common sense, good infection control behaviours from everyone means that we can start to go about our lives in a way that we recognise from sort of January, February time, and that disappeared rapidly in March. So, and actually, you know, I think it's pleasing to see that people are still adhering to the advice in the main, and people are being diligent around hand washing and starting to wear face coverings, which I think is a really positive thing to see. So long may that continue. The outbreak management plan does really link with that, in that obviously with the government's easement of lockdown restrictions during June and July, we're starting to see people going about their business more like we recognised in January and February, and like I say, that's good to see. However, we do need to remain vigilant to the fact that the number of cases could rapidly increase again, particularly in some of our more at-risk settings like care homes, which still remain a setting of concern for me, as it should do for everyone else. I think it's been highlighted through COVID-19 that care homes are particularly vulnerable, so we need to continue to protect them and work with them accordingly. So as part of the easement of lockdown restrictions, the government requested that local authorities with their partners develop outbreak management plans. so that we're able to respond rapidly when we're seeing localized outbreaks. Now, there's been a lot made of the kind of geographical outbreak scenario, so that the whole Leicester lockdown is one that you'll have recognised from the media. However, my personal assessment of it is that it's much more likely for us in the borough to see settings-based outbreaks. And I mention again, like care homes, schools, businesses, for example, or indeed certain kind of more tight-knit communities, minority ethnic community, and some of the smaller geographical areas within South Tyneside where communities are much more close-knit. So they seem to be more risky areas for us in South Tyneside, and that's based on our kind of local intelligence and knowledge of where we might see cases start to increase. The local government were asked to take the lead on developing these plans and publish them on their websites by the end of June. So our outbreak management plan in your pack today is actually on the council website, and we published it after developing it very quickly with our partners. We tried to consult as broadly as we can do and take views on board, but obviously there was a time pressure to it. But one of the things we did agree is that in publishing the outbreak management plan, we weren't going to have the perfect plan. It's going to be subject to testing, and it's going to be subject to implementation, and we'll learn rapidly throughout those processes. So we very much build it as a working document. So the version that's up on the council website is very likely to be amended and changed, not least given the government's announcements over the weekend about additional powers to local areas to be able to control outbreaks as well. So we need to update the plan accordingly to include those powers. I may show you the governance structure. I'm just trying to bring it up. Give me 2 seconds.
Tom, it's in the copy of the plan. We've all had the enclosures, so we don't.
Yeah, well, I'll tell you what. I'll just bring it up for myself then, so I can talk it through. So it's if within your plan, if you turn to the terms of reference section at the back of the plan, I think it's page 22 of the governing body packs. You'll see a governance chart. Has everyone got sight of that? Yeah, jolly good. It just might help me talk through the plan. So in order to oversee and develop the plan, we established a COVID-19 outbreak leadership board. That's a splinter group of the Health and Wellbeing Board. Some areas have used their full Health and Wellbeing Board. We felt we needed something a bit more agile, given that our Health and Wellbeing Board only meets every other month. So we established this COVID outbreak leadership board, which is chaired by Councillor Malcolm and vice chaired by Matthew. That group has signed off the plan and overseen its development. The group that's predominantly did the legwork on the plan sits underneath the outbreak leadership board, and that's the COVID-19 outbreak management board. That's chaired by myself and includes partners from across the system, including your very own Jeanette. And the role of that board is very much to kind of pull together the threads of learning from the individual outbreaks that may or may not be happening across the system at any one point in time. And the aim there is to make sure that we're coordinating our response and deploying resources accordingly. We're also very keen that we look across and learn from different outbreaks that are happening in the country, because there's some key lessons to be learned there. So we've got a real good process around, a really robust process around continuing bringing back feedback from outbreaks that are happening across other parts of the country, such as the Leicester situation and other localised outbreaks that we've seen in places like Kirklees. And then underneath the outbreak management board, if and when outbreaks occur, we will have individual outbreak control teams established. Now, we base those around 4 key themes. So we based it around adult social care and care homes, schools and early years, businesses and workplaces, and communities of interest as well. So if we see an individual outbreak, an outbreak management team will be established. Public Health England leads those individual outbreak management teams. However, if we do see an outbreak in, for example, a school, and then a couple of days later, we see an outbreak in another school, rather than having 2 separate outbreak control teams, we'll simply manage it under 1 outbreak control team, which is why we're based it around those themes. The outbreak control teams are going to be much more operational, so they'll meet on an as and when basis, but they'll be feeding back up into the health protection board that sits above that, chaired by myself, so that we can be just coordinating across the whole system. As I mentioned before, we will be keeping a very close eye on the learning that we get from those individual outbreaks and updating the plan accordingly. And our key next step, as I mentioned, is to update the outbreak management plan in line with the announcements around local powers as well, and how that might be played out in reality. Given that we are currently not, touching wood, seeing individual outbreaks in the borough, we are running some test exercises based around those themes, where we've built a number of scenarios and we're running through those as individual outbreak control teams. We recently did one with businesses and workplaces, and we had a couple of key workplaces in the borough come and join us on that, which was excellent. So we had a restaurant chain that also does takeaway service, and we also had a food processing company as well who joined us as well, and they were able to share their lived experiences and what they would do in practice based on those scenarios. Making sure that we're engaging with all the kind of key settings on that, including some of our community leaders, particularly from the Black and minority ethnic community. So I'm happy to take any questions from there, really. I think I've given you a bit of an overview. Hopefully it's given you a sense of what the plan looks like.
Thanks very much, Tom. That's good to hear. Obviously, I'm part of the mechanisms around this. I think from my point of view, it's the agility and speed of response is key. And I think we've set up something that can be agile, respond quickly, but learn and learn quickly as well. So I think I'm very heartened by what we've got here. There was a couple of technical difficulties. I think there you broke up a couple of times during that presentation, but I don't think there was anything key that was missed as far as I'm aware. Colleagues, any further questions or comments for Tom on the outbreak management? Nope. Okay, in that case, we'll move on. I think, Matt, you're going to present the performance report as a presentation rather than the usual large data that we tend to get. Is that right?
I'm going to attempt to. We are having a few network issues here, so I apologise in advance if that's a problem. I'm going to share my screen shortly. I've just tried to boil this down to those 4 metrics that we looked at nationally. So we scrutinised on nationally, so around how long people wait before they have their elective treatment, how long people wait for diagnostic tests, how long people wait for cancer tests, and how long we take to treat people in A&E. So I know there's quite a lot of data in here, and I will try and make it accessible if I possibly can. Matthew, you're the only person I can see on my screen, so if you give me a nod if you can see that, that's looking okay. Right, so if we start with elective plan care, I mean, the key point of these slides really is to give you a sense of performance, yes, but not in a green or red sense, more in a case of how we've been doing through the COVID period and the challenges that face us given the changes we've seen in activity. So, and apologies for the late distribution of these slides. We were trying to get the most recent data we had. Hopefully you can all see that slide with a big red line through the middle of it. Matthew, you're the only person I can see on my screen, so I'll just assume that's working unless you let me know otherwise. The key point of this chart is to say, look, you can see roughly we had around about 3,500 elective referrals, so referrals mostly from GPs to hospital care for outpatient appointments over the last couple of years. And you can see during that COVID period, we dropped to around about 1,000 elective referrals per month. So a significant drop of around about 2/3 of our activity through that period. Now, we could work on the assumption that there's still a large number of patients who would otherwise have perhaps come to see their GP and therefore would perhaps been referred on for secondary care, and they somewhere will be needing some support and some advice, some treatment at some point in the future. So we're going to have a significant issue to deal with as we start to move forward. The next chart is the same picture, so it's the total number of referrals made per month, but this is by the deprivation quintile. So if you split the population of the country up into 5 chunks, with the most deprived being that brown line at the top and the least deprived being the green line, what this shows you is each of those quintiles had roughly the same pattern of change. So I guess the key thing which is perhaps helpful for us is we didn't see a greater drop proportionately in our more deprived areas than in our least deprived areas. However, as you can see, most of our referrals came from the 2 most deprived quintiles of the population. And that's not surprising given that most of our population sits in those quintiles more generally. I know this doesn't tell you a huge amount this slide, but the reason I put it up is as we move forward with performance data, the governing body has challenged us to think about health inequalities, and we will be trying to look at how our recovery is progressing by quintile. So are we genuinely having a disproportionate response and supporting our more deprived patients more? Now for the next few slides, there's 2 axes, so I apologise in advance for that. The blue columns all relate to the left-hand axis, and when you see a red line, they'll relate to the right-hand axis. So if you look on the left, you'll see it's the total number of patients on incomplete elective pathways. This is the measure of RTT, we call it, of people who have been referred for treatment and are still waiting for that treatment. This shows you the total waiting list size. So you can see that overall through 18-19, we had about 10,000 patients at any point waiting for treatment. Obviously, more people are added to that list through referrals, and as people are treated, they come off that list. It increased into the last winter to about 12,000, but into the COVID period, you can see that for April and May, the waiting list size has dropped to about 8,000 patients currently waiting for some kind of treatment. That isn't because we've been able to see more patients. That's because the referrals have declined as people stayed at home, didn't come to see the GP, and hence weren't referred into secondary care. So that is something we'll have to manage as we move forward. And hopefully you can see the red line that relates to the right-hand axis. So this is what we call performance, the 92% standard. So we need to have no more than 92% of patients seen within 18 weeks of their referral. And you can see we've been really good at that historically, but as we've got into March, April, May, as it's become much more challenging to see people in hospital, to have that treatment undertaken with infection prevention control and social distancing, that performance has been much more challenging, and we're going to expect real difficulty with that moving forward. Just finally on elective care, this shows you the number of people who've been waiting more than 52 weeks for their care. Is the orange chart, and 48 to 52 weeks to give you a sense of those people who are approaching that time. You'll see historically we've had very few people who've waited more than 52 weeks. We've been really good at managing, making sure that people haven't had long waits for their elective, their planned care in South Tyneside. But clearly, as we approach April, May, we're now getting those 50, 60 people who have been waiting for a long period of time for their care. And that's something we're working through with the trusts. But clearly, we've got real challenges in how much capacity there is to be able to undertake elective care moving forward. If I just come on to diagnostic tests. So again, looking at the left-hand axis, you can see that we roughly have undertaken about 5,000 diagnostic tests a month for South Tyneside residents up until the COVID period. So these are things like ultrasounds, MRI, endoscopy, and so on. And again, you can see into April that really dropped to 1,000, 2,000, and 3,000 in May and June. So really significant. This white space here reflects a large number of patients who we might ordinarily have expected to have diagnostic tests who haven't been able to have them. And as a consequence, the red line relates to the right-hand axis. So this is the patients who've been waiting longer than 6 weeks for their diagnostic test. And you can see that we had very few of those patients. We've managed this very successfully historically, but there's been a really significant increase. So there are currently around about 1,200 patients who've been waiting longer than 6 weeks for their diagnostics. And again, it's going to be really challenging to manage that, to help reduce that waiting time with the increased infection prevention control requirements. If we look at cancer treatment, it's a similar challenge. So these are the number of patients who were seen after a 2-week wait referral. Again, roughly 500 a month for South Tyneside and declined to 200 or 300 And that's because we know that patients haven't come forward to see their GP and haven't therefore been referred in for a 2-week wait. So there are a number of patients who we might ordinarily have expected to have come forward for to be referred in to be seen by a specialist who haven't been. The red line relates to the right-hand axis, so this talks to you about the percentage of those patients who were seen within 2 weeks. So once a referral was made, within the number of referrals has dropped, but actually most people, when referred in, have still been able to be seen within that 2 weeks. So that is something that's really positive. Clearly, as we move forward, this group of patients we would expect will come back into the system, and we will have to make sure we balance capacity and demand. This is a number of patients who were ordinarily treated within 62 days of that referral for their cancer treatment. So you can see roughly 40 to 50 patients a month treated for cancer, from South Tyneside. You can see in May that number dropped to about 20. And that, if you think about the 62-day delay, the delay by the time you've had your test and have your treatment, that reflects that drop in referrals we saw in March, April and into May. So we can probably expect that will continue for the next couple of months. And again, the red line relates to the right-hand axis. So although we've seen less patients, actually those patients have been seen broadly within that 62-day period. So the target is for about 85% of patients to be seen within that period. And just lastly, because I know I've presented a lot of data here, if we look at emergency care, so this is, again, the columns relate to the left-hand axis. This is the number of attendances per day at South Tyneside District Hospital. Now, the orange bars relate to what we call type 3. That's activity at the urgent care centre. So not in the A&E department itself, but in the urgent care centre that is on the South Tyneside site. You can see activity. We worked really hard following the first half of last year to increase activity to about 50 patients a day. During the COVID period, that's dropped off, but it has now recovered back to roughly where it expected to be. The blue columns relate to the activity in the A&E department itself. And you can see that actually with all the work we did with the urgent care centre, we managed to reduce that down. So more people see an urgent care centre in the winter than previously. But clearly the number of A&E attendances dropped off markedly between March, April and May. And it's now recovered to roughly about 80% of the previous levels of activity. So we're not quite back to the levels we were seeing last year, but activity is slowly increasing. And I know this is a very busy line, but this relates to performance against the 95% standard. So you can see we had a very challenging winter here in the middle, and actually performance has been reasonably balanced over the last few months. But as I say, we've had a much smaller number of patients coming through than we normally expect. So I know that there's a lot of information there, but I guess I just wanted to try and give a sense of how the activities changed and how we performed in relation to that. And I guess the key message I would leave you with is clearly there are a large number of patients who we'd normally expected to have come through our system in between March and June who simply haven't. And we will need to manage that as we move forward. And I think that's probably about it, Matthew.
Thanks, Matt. That's really helpful way of presenting what's often very complicated data for us. So thank you for making that, although complex, relatively easy for us non-statisticians to be able to follow. Anybody got any comments and questions for Matt? Kate, what from you?
Yeah, I suppose it's just an observation, and I agree, really useful information, but it does just highlight, I suppose, that the issues that we've got going forward in terms of turning activity back on. There's going to be quite a significant backlog of patients who need to be seen, but at the same time we've got to recognise that there are limitations around social distancing and infection protection control. So I think we have to be realistic about what can be turned on when and how long it's going to take to get through this backlog. And I suspect there'll be national messages about what needs turning on and how quickly, and I think we need to balance those two things out.
Yeah, no, I agree.
I think Pat and then Neil.
I think Neil might have been wanting to come in on Kate's point there. Was it, Neil?
Just quickly to add to that, I think the approach that we absolutely have to take as an NHS is that of safety. You can switch on a whole load of services, if you like, which I'm not saying are not essential services, but won't actually impact the life expectancy, quality of life of individuals. We need to look at it through that lens as we focus our precious resources in the restart. I mean, the number of over 52-week waiters there I mean, what you don't want to do is, I don't know, I'm trying to think of something, fix someone's hernia before you give someone cancer surgery, for instance. Do you know what I mean? So there has to be a safety, quality of life, and kind of life improving lens put on this, and it will cause difficult decisions, I think, in the startup. But I think that is the right thing to do. So we're working on that across the ICP, because the other thing as well that we need to make sure is that not one part of the population in our national health service is disadvantaged because their local hospital maybe can't switch certain services on quicker than, say, one a few more miles away. But if their clinical need is greater, patients might actually be okay to travel 20, 30 miles. Do you know what I mean? So we need to be able to have those conversations, look at clinical risk across a larger population, and be fair and do the right thing when we switch on. And that's the approach that we're taking. Make sure the service is safe and equitable for patients.
Thanks, Neil. Do you want to come back on any of that?
Yeah, I guess just to reflect that and hopefully provide some assurance. So obviously, Neil, you've established that clinical strategy group, which you mentioned in the accountable officers report, and there's also the clinical pathway group that's sitting more locally, so across the GPs and the secondary care consultants in Sunderland and South Tyneside, looking at exactly that. So how do we make sure we make really, really sensible clinical decisions? How do we make sure we prioritise the right pathways, the right use of capacity in that way? So I think you're absolutely right, and we're certainly working on that.
Good.
Pat, did you want to ask a quick question? And we do need to move on, probably, because we're getting...
No, actually, mine was around safety and quality, which Neil and Matthew have addressed, so thank you for that.
Okay, fine. In that case, I'll move us on. Thanks, Matt, for the the presentation there. Move on to the finance section. 2 papers from you, I think, Kate.
Thank you, Matthew. So if I start to sound like a robot, which has been happening a little bit this morning, just wave at me and I'll try and pause until it's better again. So I would refer you first instance to enclosure 5I, which is, I think, page 103 of the pack. That's the standard finance report I have brought for you, usual format. There's some repetition in the information in there from last month with regard to the financial framework. And you'll see that we've reminded colleagues that we have a financial framework in place until the end of July, which is expected to be, I think, rolled forward for a couple of months, but we haven't had that confirmed yet. And then there's some further information in the report regarding what might happen from month 5 onwards, which I think is a bit more pertinent to our conversations today. So I'll maybe focus on that. So it's anticipated that I think that the current framework will roll forward for a couple of months, and then they are going to allocate to CCGs an allocation based on their understanding of what CCGs are going to require going forward. We are submitting information to NHS England at the moment and refreshing it, as is every provider and every CCG in the patch nationally. Some of the numbers in there are going to be quite eye-watering, I think, for NHS England nationally, and so there needs to be a really good understanding of what's driving those figures. And I think that just plays out to the fact that they're trying to make a national calculation of what is needed, and we're trying to say, actually, no, locally, this is what we're saying, how our things play out against your national assumptions, basically. We're trying to do that on a consistent basis across the ICS of North Eastern Cumbria, and we will be refreshing that information over the next couple of weeks so that it can be collated and try and understand it a little bit better. On top of that, we're anticipating getting COVID allocations at an ICS level, although more recently I've heard that they might actually come out at an ICP level. That hasn't yet been confirmed, but we do know that COVID costs will be sort of handed out to our area as a one-er, if you like, and that it'll be for us to agree as a system how those funds are distributed across the hospital and commissioning sector, which could lead to some interesting conversations, I think. And I did allude to it in the paper, I think, that there have been historically and will always be voices that will shout louder as to what the priority is. So we need to make sure that we are well represented in those conversations. But equally, I think that we are clear about the reasonableness of what our ask is in terms of COVID costs, going back to the section in the paper about what we were submitting earlier about things being reasonable, specific and additional. We have to be able to evidence why we need the funding that we do. But that will be to play out from month 5, possibly 6 or 7 onwards, I would suggest. Just in terms of headline numbers, within the report, we've got a position stating 2.5 million overspend. That's for the month 1 to 4 position. More recent work that Sue and Matty has been doing would suggest that we're looking like a 4.6 million overspend if we continue with the financial regime as it is. So there's lots to work through, and as I say, other colleagues are doing the same. I'll pause there because I see John's got his hand up. John, did you want to ask a question?
Yes, please. It was about some elements of the report, please. How does the COVID expense claim that you've made for South Tyneside CCG sit when you consider it against other CCGs? I've seen some variation on different figures. I just wondered where you were in the pack, sort of thing, in terms of benchmarking.
Off the top of my head, John, I couldn't tell you. I'd have to have a look, and that's part of the work that we're doing as a region. But I don't have access to that at the moment. Sorry.
Okay, thank you.
Were there any other questions on the finance report?
So,
yeah, could I ask another one, please?
Go ahead, John.
It was about I think I know the answer, but it's just for reassurance. You know, we've approved emergency delegated limits.
Yes.
Have they been used much?
Well, I was going to touch on that in the next report, but
sorry.
Yeah, no, that's absolutely fine, John. I would say no, not really.
Okay.
Yeah, not massively.
Thank you.
Any other colleagues want to ask questions on the finance report that Kate presented before we move on to those? Matt and then Neil.
Well, I guess just an observation. It reflects a really challenging position, doesn't it? I mean, I guess it's sort of stating the obvious, isn't it? But we've got some real challenges there.
And I've just realised one of the things that I didn't say is that factored into all of these numbers is actually an assumption that we have our surplus returned to us. So essentially, our surplus will be used up for COVID costs or system costs as a result of all of this. So that possibly isn't what we would have chosen to do with the return of that surplus, but that's factored into the calculations at the moment.
Okay, and Neil.
So I think it's fair to say there is a huge amount of financial uncertainty. Nationally, it seems as though we're advised 2 months in advance of what's happening financially. I think the ICS will have a greater role in determining any top-up funds, and I'm engaging actively with the ICS to ensure local populations are represented in that. So it is just to really say to governing body, there is a lot of uncertainty at the moment that may well delay some investments into some things that we may be planning to do. But we are engaged regionally, nationally to try and get that clarity. Once we have it, we'll feed it back. But it's a very, very uncertain picture. And you know, South Tyneside CCG hasn't historically had a financial challenge. So it is, as I say, we need to see how this develops over time. It's just really to get the point across of uncertainty. That's all.
Yeah, I would agree, and I think I have to recognise that part of the uncertainty comes from the fact that Department of Health is still in negotiations, discussions with the Treasury about the amount of funding that will be made available to support the system. So until they can land those conversations, then we can't have any further guidance out. So it is very uncertain and not the best way to be operating, but it is what it is.
Yeah, I think it's a point well made that the uncertainty at that level is translating down into uncertainty at our level, difficulty with producing any sort of financial plan, which goes on to have a knock-on into the effects of planning investments and service changes that we might otherwise have wanted to make. So it's seeing that cascade of uncertainty and how it's affecting changes we might want to make on the ground. Really, it's important, isn't it?
And just to be clear, that's not a criticism of the national team. I think it's immensely difficult and complicated for them to work out how to resource the response to COVID crisis and resource the switch on. So I can understand why it's taking time, but and they know that it's causing some problems locally, but I think we just need to work with them on that.
Yeah, I agree. Thanks, Kate. Do you want to take the second report on the scheme of delegation quickly as well?
Yeah, thank you, Matthew. So this is enclosure 5II, I think on page 117 of the pack. I've written it down because I can't dot between the two things very well. So it was just to say, and picking up John's point, we did put in place a revised scheme of delegation for the period up to the end of July. It hasn't been used extensively, but equally I don't think it's placed us at any undue risk as an organisation, and my proposal would be that we roll that forward to the end of the financial year, because there may be another surge of COVID which we need to respond to. We may need to set up hubs and things like that again, in which case people need to have that flexibility to act, and I think it doesn't place us at undue risk, and my proposal would be to continue it to the end of the year.
Thanks, Kate. Anybody have any dissenting voices around the table to Kate's suggestion? No, all quiet, so we'll agree that in that case, Kate. Thanks very much.
Thank you.
Let's move on then to the commissioning section. Matt, a brief report on the delegated primary care commissioning before moving on to the end of the report.
Yeah, so probably quite a brief update on the primary care commissioning. So we're required to put forward a short paper each year setting out the arrangements we have. So you'll know that in April 2017 we took on what we call level 3 status, so fully delegated authority from NHS England for the commissioning of primary medical services, general practice services. And to enact that, we have a primary care committee which meets in public, also has a private part, meets in public after this meeting. Has representation, as you can see, from the CCG, NHS England, our council and Healthwatch. And that is supported by a primary care quality review and business meeting, which is co-chaired by myself and Jeanette, the Director of Nursing Quality and Safety, which takes forward all those operational decisions and reports into the primary care committee. So we're really just asking the governing body to note the, sorry, I've lost my page. We're asking the governing body to note the paper that you've got in front of you, and note the mechanisms that we have in place to manage those primary medical services contracts.
Thanks, Matt. That is what it is. I'm sure we can all note that. Does anybody have any specific comments or questions around that paper? Nope. Okay, we'll note it for information. Thanks very much. And move on to the end-of-life palliative care model update paper.
Great. Thanks, Matthew. So we talked a little bit about this in the May governing body, and I guess the first thing to say is we've had, clearly with COVID, all the efforts of the NHS and our partners have been focused on the response to that. So when it comes to some of the later sections in the paper, people might have expected more progress than we've been able to actually achieve. So I apologise for that. So as you can see at the start of the paper, we reflected on the fact that actually, sadly, lots of people have died from COVID, and Tom touched on that earlier in his paper. I think it's fair to say the palliative and end-of-life care services that we've developed over the last year or two have really allowed us to respond well to that. So we've seen a much higher level of mortality in people's homes than we would normally have expected. And the teams have really been able to support people to have a dignified end of their life at home and in the communities that they live in. So when I come on later to talk about the co-design exercise, what people told us is that most people want to die in their own homes. They want to be able to be looking out the window they've looked out of for most of their lives when they come to the last few days. So that's what we'll be really focused on trying to achieve. So we mustn't lose sight on that as being a key driver, because sadly in the past we've been really good at identifying where people wanted to have the end of their lives, but not necessarily brilliant at following that through. And more people have died in hospital historically than we certainly would have liked and that they would have liked. So this paper gives you a bit of an update on some of the changes we've made over the last 6 months or so, the impact they've had. So if I take you to the section that's titled Community Services Palliative Care Team, we recognised that actually we had a good out-of-hours offer, but the service through the day wasn't as robust as it could have been. So we've invested in the community palliative care capacity. That decision was taken last year, and that's provided both planned and unplanned care during the day, So it's been particularly nursing, supported by some additional consultant capacity. And then that's, as we've seen COVID increase, we've also put in some additional capacity into the out of hours team from about 4 p.m. to midnight. And those two things have really helped us to be able to support people to die at home. The next section, and Louise might have some thoughts on this, but we've worked really hard with community pharmacy colleagues. We've got an excellent community pharmacy team, community in South Tyneside, and they've worked really well with us to develop that on-call pharmacy service and increase the number of pharmacies who hold particular palliative care medicines. And it might seem a point of detail. This is a really important point. If there's a need for a particular medicine overnight, then actually getting really quick access to that for staff and patients is really important. Then coming on to primary care, I particularly picked up the point about the do not attempt CPR, the DNA CPR documentation from a specific question we had from Healthwatch, but actually there haven't been any specific concerns that have been raised about that locally. And I really reflect it only because of some national questions that were asked a couple of months ago, but I thought it was helpful to include that in this paper. And the other element that we've introduced, which has worked really well, is that GP weekend advice line. So over and above the out of hours, existing out of hours offer, having a local GP working Saturdays and Sundays in Clarendon with the community nursing teams has really allowed us to connect all of the pieces together for those people who are coming towards the end of their lives. And I think that's been really, really successful. And then just finally coming on to the end of life care co-design, as I mentioned earlier, when we asked people what they wanted, people said they really wanted to be supported to die at home. And actually, none of us would have wanted the COVID period to come, but over that period, we have been able to support a much greater number of people to pass away at home than would previously have been the case. Many people would previously have been in a hospital bed, for example. And that's because of that extra consultant capacity, extra nursing, the fast track home care, and we're working on these, the urgent overnight home care and the complex home care services, which will be coming online soon. But because of that COVID period, we've really not had the capacity to be able to move on the physical hub that we talked about developing in the palliative care beds. So we've been working really hard on COVID. Unfortunately, we've not been able to do that transformational work. Our clinicians have been focusing on dealing with the patients rather than be able to step aside and look at the transformational project around this. So it will be September before we're able to bring a proposal, a final proposal, to the governing body. And I think the point I've made at the end of this paper is really important. There's something that Neil touched on, the financial uncertainty we're facing, as did Kate. So there are two issues for us. Certainly, the landscape for us to make significant investment decisions is much different to what it was in a year or so ago. And we'll really have to reflect that in the decision we make in September. And secondly, we've talked a lot about the opportunity to make sure we engage charitable fundraising in our decision making, but we have to be realistic that the advice we're getting about the economic position of the country means that may be much more challenging. So it's quite possible that it'll be a very difficult decision that we have to make in September about how we develop that hub with the inpatient beds, which we still want to have in South Tyneside. So I'm sorry that we're not able to bring a lot more detail, but I hope that gives you a bit of a flavour of where we're up to. I ask you to note the paper and note that there'll be a much more tangible decision-making paper to come in September.
Thanks very much, Matt. I've got Jeanette with her hand raised there, and then Pat, I think.
Yeah, thank you, Matt. I just want to point out that although I know there's been a delay in being able to develop the case around bed-based care, I'm really reassured around the improvements that have been made around supporting people in their own homes, because that was definitely an area that we had lots of feedback from people in the communities, and so that has to be a significant improvement for people. It's offered confidence in that choice, because the support is now available to a greater degree than it previously was. So I think that's, I just want to note that that is a significant improvement, and that fits with lots of information that's been fed back to us through patient stories and patient experience that we've heard. So I just wanted to comment on that. I appreciate that it's still not complete yet, because we do need to think about that, you know, the final sort of piece in the jigsaw. But I think the other thing I was going to mention was, because it's the same theme as the care homes, I think we need to just note how important GPs are in all of this, because when we were in COVID and we had the specific advice and support service for care homes, and when they were dealing with people with symptoms of COVID, that was really well received and was really responsive. And then we're hearing the same thing about the access to GPs for advice for people who are palliative or end-of-life care at home. And so I think it's just important to recognise that you know, GPs have got a really important role in this. So it's the whole spectrum of professionals involved.
Thanks for those comments, Jeanette. I'm not going to argue with you. We'll move on. Pat, if you have any question there as well.
Thank you, Matt. And I think thank you for the honest paper and telling it as it is. And that's what we need to be aware of. So building on that, there's a couple of things. First of all, in terms of comments, it was really good to see the initiatives that had been put in place during COVID. And it's really good to hear that the feedback from Jeanette, that through the patient stories and feedback that we're getting, that those initiatives worked. And I think thank you to everybody for that. I think we have some difficult decisions to make. I appreciate that. For me, it's around how we ensure that we have the feedback from public, patients, and the GPs as well, everybody who needs to be involved in that to help us make those decisions in that realistic world that we're facing. And I'm looking for some assurance that when we get the paper in September, that it will give us that information to assist us as governing body members to look at that. And I think one other thing I would urge is that if we're in a situation where we still have this financial uncertainty, are there some decisions that we should be looking to put on hold a little bit longer till we've got a bit more certainty about finances, rather than make the wrong decision earlier?
I think that's a really important point, Pat. Matt, I don't know if you want to to that.
Yeah. So on those 2 points, so absolutely, Pat, yes, I think you're quite right. So we obviously undertook the big listening co-design exercise last year, which drove all of the proposals that we put forward. But you're right, we'll make sure that we're clear about how we've engaged those views in the paper that comes in September. And I think you're right. I suppose there's a question about what do we bring in September? Is it something in terms of the context as we understand it at the time, or are we looking for perhaps a time when that financial uncertainty might be less uncertain, if you see what I mean? So, well, I'll perhaps talk to Neil and Kate about how we might take a view on that over the next sort of 6 weeks.
And I think it's important that we note that the governing body specifically is not asking execs to bring a paper for a decision if they feel it is the wrong time for a decision. You know, we would like to make a decision on this as quickly as we possibly can, but equally we need to make the right decision. And if we can't make a decision quickly with confidence that it will be the right decision, we must postpone it again. Not what we want, but we must do it if there's a risk of making the wrong decision through uncertainty. People must be happy with that. Okay. Thanks very much for the report, Matt, and for sharing what's been going on so far. Let's move on to the next item, which is the Governing Body Assurance Framework. I think, Keith, you're going to take us through this quickly. Keith, you're still on mute.
Yeah, thank you, Matthew. We did take a view before we did this piece of work about whether we should actually undertake it at this point in time, given the circumstances in which the CCG is operating. But we took a view anyway that we should, and tried to reflect within the board assurance framework the current circumstances, basically. And I think turning to page, if I can signpost you to page 134 in the pack, which is the second page of the cover sheet, I think it's probably assuring to know that although we have put in place interim governance arrangements and decision-making arrangements, much of the framework and the architecture has continued to operate in terms of assurance. This governing body has continued to meet, and indeed a number of the governing body's committees have actually continued to meet at this time as well, sometimes with reduced agendas, but effectively still operating and still addressing a number of very critical issues, as we've heard today. We've included in the revised assurance framework also obviously, as you would expect, COVID-19 as a specific risk. We've scored it highly. We've scored it quite high as a residual risk of 20, which is again reflects some of the discussion that we've had today about the current uncertainties that still persist, I guess, in terms of resources and how quickly sort of recovery plans and restart will actually take place. And that's also, I think, reflected in risk 1909, which was one of Kate's areas in relation to finance, again, in relation to the discussion that, in fact, we've just heard about the uncertainties about the financial arrangements with the sort of command and control arrangements that have been in place and the different funding arrangements. So we've adjusted the assurance framework to pick up some of the issues, and I suspect, given where we are, the assurance framework that we've got, subject to again further revision, will remain in place for the remainder, I guess, of this financial year, perhaps in pretty much in this form, with that sort of content. Actually, I'm very happy to take questions.
Thanks, Keith. Anybody got any questions, comments for Keith? Pat?
Yeah, sorry. Thank you, Keith. It was a great paper. I particularly like the front sheet, alerting us to the key issues. Just one thing is for me is the action on gaps, where there are gaps of assurance, and I'll just come to, I think it's risk 238. It's the controls regarding clinical leadership group for the ICP, and I think there was. I think there's the clinical leadership group for ICP to make the strategic recovery decisions, but the group's yet to meet, it states. And it's got in the gaps in assurance, the meeting hasn't yet met, but we actually don't have anything on the action on gaps. I think that's something that we need to address, please.
Yeah, something Neil might want to comment on. It's probably a timing issue of.
It could be that I've actually got that written down. Is it just a timing issue?
It has since had its initial meeting. We've got another meeting planned just after my leave in August, where we'll be looking at clinical strategy, how it fits in with ICP and CCG governance. So we'll have an update on that.
Right.
So we can update. We'll update the assurance framework accordingly.
Okay, thank you.
And
that's good.
Yeah, just one other, and this was around the Children's Safeguarding Improvement Plan, which was paused during COVID. And just a case of asking again from a risk assurance point of view when that's resuming.
Jeanette might be best placed to answer that. Again, it may well be a timing issue, I suspect.
Sorry, Pat, I missed that question. That my connection's a little bit funny. Could you just repeat it, please?
Yeah. It was around the chair. Given all of the issues around COVID, this is particularly important, high risk. So it's around the Children's Safeguarding Improvement Plan. It was paused, and I'm just looking for some assurance that there's a time scale for that being looked at again, restated. Yeah,
so that's already restarted. Right. There's a date, and when I say it's restarted, there's a date for that to be picked back up, which is this month. So it's happening within this month.
Thank you.
Thanks very much. I think we shall accept the report then, Keith, and move on. Thanks very much for that. We then have the report from the Patient Public Involvement Practice Engagement Report, which was for information only. don't propose to spend any time discussing that. It's a report on what's gone on during the year. We have the usual list of set of minutes from various subcommittees for information only, unless anybody has any thing that they really must discuss from there. The cycle of business for information and for people to let me know if there's anything they feel that needs to change from that. And I've not been informed of any other business that we need to talk about today. Have, however, had 2 questions come in from members of the public through the course of the meeting. So there's 2 questions from Roger Nettleship, one which I think is probably best directed to Neil O'Brien, and one that he's suggested may be best answered by Jeanette Scott. So I'll read them out, both of them, and then let you each answer in turn. So questions, Neil, regards talk before you walk, and he's raising concerns that what this could mean if people present to A&E themselves without talking before they walk, particularly if it's late at night. What would happen if people turn up without talking before they walk? Would they be turned away? Would there be issues around transport potentially that would come from that? Would people be vulnerable outside A&E departments and not allowed in? I wanted some reassurance that they must have the option to be able to turn up at A&E departments. And the second question was a question about COVID, and it was about concerns that expressed that COVID-19 patients who should have been admitted to ITU that were not, apparently. I'm not quite sure what any evidence for that, but reports that ITU in South Tyneside saved a higher than average number of patients on ventilators by using a different type of ventilating patients and piloting treatments differently in South Tyneside, and asking about how they performed and whether best practices being adopted. So again, I'm not quite sure that that's the right. Not quite sure what the substance of that question is. Matt, you got your hand up there. Was that about that second question?
Yeah, just to point out, Chair, that Roger and I have a call this afternoon, so it may be that we don't have all of the answers to some of those quite detailed questions now. So if you want, we can go away and pick it up, and I can always talk to Roger about that later. Yeah, just if that's helpful.
Yeah, I suspect that nobody's going to have the detail on that at their fingertips around this governing body, but if you're able to pick that up later with Roger, that would be great. And then we'll ask Neil to respond to the point about talk before you walk.
The short answer is no. People will not get turned away from A&E. There is no local or national desire to put unnecessary blocks in people accessing emergency care if they feel they need to. What we are looking at is behaviour change and trying to get the message across to the public that it might actually be better for you if you talk before you walk. Because let's say, for instance, if it's relating to a long-term condition, it's much better if you see your own GP who has full access to your medical records, say during the day, than if you were to go to A&E and frankly be often seen by a very junior doctor. So it's about getting people to the right place, but no, that you won't get turned around at the front door and say you haven't got an appointment, off you go. That's not the way we work in the NHS.
Okay, thanks very much for that answer, Neil. I hope, Roger, you found that reassuring. Jeanette, you wanted to come in as well there?
Yeah, I mean, I think Matt's probably going to have a much more detailed discussion with Roger and today, and probably be able to pinpoint what the key queries are. From a general point of view, my response would be this is about senior clinician decision making within the trust on a patient by patient basis. So I think it would be very difficult for us to comment on that. And I would just refer back to the point that I made earlier around that big piece of work that the Trust carried out and presented recently, where they analysed all of the mortality that was related to COVID. And if there was issues around whether they got the right level of care, that would have been picked up if they didn't optimise the level of care, and certainly that didn't come out of that big piece, the big review that was carried out around the cases that were cared for. It's very sad when that people have died from COVID, but there's no indication that senior to clinical decision making was questioned at all from that review.
Thanks very much for that, Jeanette. That's a helpful comment to bring to bear on that. I hope you found those answers reassuring, Roger. I make it 11 o'clock now. Time for us to finish the meeting. Thanks to everybody for your contribution. Could I ask colleagues to stay online for a few minutes just so that we could do some brief reflection once the streaming of the public part of the meeting has ended. Thanks very much, colleagues, and thanks very much to members of the public for your interest. Thank you.